We're now at the time, and I think we can get the presentation loaded and ask Dr. Sturesson to go ahead and get started. It's now 1 minute past, so perfect timing.
Thank you very much for inviting me to this seminar, and I will talk about the thing to identify patients with postpartum sacroiliac dysfunction. Are they different? Here are my disclosures. My name is Sturesson. I'm working at the spine unit at the hospital in Ängelholm, located in the south of Sweden. 50% of women during pregnancy have low back or pelvic pain during the pregnancy. Half of them have pain originating from the pelvic joints, and that was found many years ago, first by Mantel and later by Östgaard, and then a lot of more speakers like we heard today. I would say there is no difference in the symptoms and signs in the post-pregnant women compared to other patients with pain from the pelvic joints. The important message is that the connective tissue need around 18 months to recover to the as good as possible situation like before the pregnancy. So actually my message is that patients with pelvic girdle pain after pregnancy shall be treated as all other patients, but decisions about surgery shall not be done before 18 months after delivery. So I will simplify the issue and return to the question, how to identify a patient with pain originating from the sacroiliac joint. The answer is, you need to use your diagnostic toolbox: history, clinical examination, MRI, and the sacroiliac block. And return to the role of the sacroiliac joint. The primary task for the sacroiliac joint is to transfer load from the spine out to each leg. As well, the understanding of the biomechanics of the sacroiliac joints. The biomechanical theory of form and force closure presented by Andrew Fleming is still valid. The form of the sacroiliac joint is the joint irregularity, and the force is the muscle strength. The force is exerted anteriorly by the transverse and the oblique abdominal muscles. Posteriorly, the glute max and latissimus dorsi creates the posterior sling. More muscles are involved, both hip rotators and the pelvic floor. In the healthy individual, the sling muscles can produce an adequate compression of the sacroiliac joint. This is the rationale behind the physical exercise treatment for pelvic girdle pain. We studied the movements of the sacroiliac joint in different types of loading. In two legs standing, there is a movement in the sacroiliac joint between the positions supine and standing. The sacrum rotates anteriorly when you load the spine in standing. The movement is small, in average 1.5 degrees, and is normally distributed. Our hypothesis was to prove hypermobility, but we totally failed. We could provoke movements in the sacroiliac joint to end positions and also show asymmetric movements, but we could never demonstrate hypermobility. But interestingly, after pregnancy, the movements in the sacroiliac joint increases. By chance, 2 of my previously analyzed patients got pregnant. In red was before the pregnancy, and in the yellow, the movement between the supine and standing, 6 respectively 24 hours after delivery. So what happened was that the movements increased, but still remained within the normal distribution. This is quite interesting findings and worth reporting. We got critics that we did not stress the sacroiliac joint enough. We could force reciprocal movement in the alternating straddle position. We found 2.4 degrees of reciprocal movement at the most, but still no hypermobility. In walking, there's one loaded leg and one unloaded. The conclusion from the test, where the hypothesis was to show diagnostic movement in the sacroiliac joint, is that the loaded leg in the healthy individual has almost no movement. This is what we found when we in the 90s analyzed the standing hip flexion test with RSR. We expected movements, but we found the opposite. Biomechanically, standing on one leg doubled the force over the sacroiliac joint, thus increasing the friction, and we found the movement in the sacroiliac joint was reduced to almost nothing. This biomechanic situation is a prerequisite for walking or standing on one leg and necessary for the ability to take load on one leg. Actually, this was a proof of the theory of force closure. The swing face is partly unloaded, but we were not able to measure that. Between 1989 and 2011, I had the external fixator in my toolbox. It was used previously by Professors Olerud in Uppsala and Slätis in Helsinki as a diagnostic tool. But did it affect the biomechanics? We used the external fixator as a diagnostic tool to defend surgery. We analyzed the movements in the sacroiliac joint before and after the application of the frame. The effect was miraculous to many patients. The external fixator improved function and markedly reduced pain. Biomechanically, we found that with compression of the frame, we could reduce the movements in the sacroiliac joint, thus providing the theory of form and force closure again. These results were really a game changer understanding the biomechanics of the sacroiliac joint. The normal situation in healthy individuals is joint stability. Our study raised the issue to discuss stability instead of instability. The opposite is individuals with non-optimal joint stability. The inability to stabilize the joint is in most cases due to a painful degenerated joint. I will show you a patient where we use the external fixator as a diagnostic test. This is a post-pregnancy patient with non-optimal sacroiliac joint stability. To the left without frame and to the right with. Just look at the difference in walking speed. It is the same patient on the left side after 6 weeks of specialized physiotherapy, on the right side 2 weeks after test surgery with the application of an external fixator. The fixator is the difference between the inability and the ability to load the leg. When the minimally invasive surgery appeared, we had to stop with the external fixators, so we created a new diagnostic algorithm. We studied pregnant women at the maternity clinic in Malmö. We described the pain pattern and observed the sensitivity in the actual pressure, which at the same time was described as posterior pelvic pain provocating test by Östgård in Gothenburg. In my normal clinic, about 1/3 of my patients has had long-standing pain post-pregnancy. The pain has to be located below L5. We always use this pain drawing. Patients with sacroiliac pain suffer pain in all different types of load, standing, walking, sitting, and also lying in the supine position. Most patients sleep on the flexed position. With clinical examination and MRI, we exclude the lumbar spine and the hip joint as pain sources. We use sacroiliac joint diagnostic procedures according to the European guidelines with some additions. In this group, most of you are aware of these tests, but I am not sure if you realize how they affect the sacroiliac joint. Just look at the arrows. The S chord of the P4 test. The force is exerted in the direction of the femur, and it has to be gentle. A force of about 50 Newton is enough. The Faber, the flexion, abduction, external rotation. The pain is typically coming with a reduced ability to abduct. The reason is that pain is increasing the activity of the hip internal rotators and restrict the external rotation. Lateral compression test of the pelvic wings. The pain has to be experienced in the sacroiliac joint area and not where the examiner put the pressure. This is biomechanically to compare with compression of joint surfaces. The Gensler test, described already in 1927. Look here at the arrows. This is an unloaded test, and you push the joint to the end position of the rotation around the x-axis. And palpation for a painful long ligament. This is a very sensitive area located close to the sacroiliac joint. The active straight leg raise is a functional test. To test the function before and after a sacroiliac block is very important, and the reaction from the patient if the test turns normal after a sacroiliac block is a feel-good surprise. The load transfer test reveals the ability to transfer load from the spine to the leg. The importance of this test is to some extent fundamental. If a patient can load the leg after a sacroiliac block, it is much stronger evidence of the effect of the sacroiliac joint block than pain provocation test, because with provocation tests, the patient can cheat the examiner, but with the functional test, that is impossible. After the testing, we confirm the diagnosis with a sacroiliac block, and the joint can, in most cases, easily be reached in the inferior part of the joint. A small amount of contrast to confirm the needle position, and about 2 milliliters of local anesthetics is injected in the sacroiliac joint. Here we ask the patient to lift the first not painful side and to raise the first not painful side, and then we take the painful side. And then we do the block. And after the block, again, we ask her to lift the right leg first, no problem, and then the left leg. And she lifted so high because she was surprised of how easy it was. She has returned and restored her muscle control. And here we have the load transfer test. We check the ability of the patient to take load on the leg before and after the block. This patient makes 2 attempts to stabilize on the left leg. Look here, she tries really to stand on it. And then she got the local anesthetics, and immediately she can stand on the left leg. So she has returned her ability to load the leg. My recommendations to identify a patient with postpartum dysfunction. First, and very important, the first 18 months, support the patient, use medication without morphine, find a good physio for the patient. After 18 months, use your toolbox, history, clinical examination, MRI, and sacroiliac block. Thank you much from me and from some of my patients.
Excellent. Very, very interesting and very long history. So thank you for the great presentation. Our last presentation will be from Dr. Stark. And again, I encourage everyone to enter any questions into the chat, and we can answer them or discuss them at the end after Dr. Stark's presentation.